So just a very brief introduction of the panelists first. Ustaz Ahmed Khonji is advisor to the Minister of Health of Oman on investments. He's been actually our client on two projects we've been doing in the health sector in Oman, the Drug Treatment and Rehabilitation Center, which is an integrated PPP, and the Renal Dialysis Services Project, which is also an integrated PPP. Mr. Vikram Vuppala, founder and CEO of NephroPlus. I really recommend you look it up on the website. It's a phenomenal organization, and much to their credit, they won under competition the first PPP in healthcare in dialysis in Uzbekistan, and are well underway in implementing it right now. Karine, you've had many introductions today, but it's always a pleasure to have you with us. Dr. Mohamed Sahili established and is running a hospital system in Zambia, Medland Health Services, with two locations, Lusaka and Livingston, right? And we were talking earlier, and I particularly wanted him to be on the panel because they run a slightly different model of PPP, which we will touch on later on. I tend to call it private sector participation. I know others use that as PPP as well, and of course, Dr. Emad Dukair. Dr. Emad and I go back a very long time. He's the CEO of InterHealth Canada, which is a leading company in integrated healthcare PPPs with projects in the Caribbean, Turks and Caicos Islands, in Europe, UK, and Poland, and of course also in Saudi Arabia and so on. So welcome to our panelists. What we want to discuss in the coming, we don't have a lot of time, we have about 35 minutes, is the efficiencies that integrated PPPs bring. And this in a way is going to kind of counteract some of the messages you had in the earlier session before lunch about the benefits of not doing them as integrated. So I want to start off first of all on what makes integrated and service-based PPPs in the social sector appealing, and I'd like to start by asking Karine to answer that question first.
Thank you. So I would distinguish a bit integrated from service-based. I mean, the difference is basically the infrastructure component. In my exception of service-based, the most important component would be the service, where there could be some construction, some renovation, obviously equipment and so forth, but what matters is the service delivery. When we talk about integrated, we talk about a major infrastructure project and then the project being commissioned and going into the service. And there the problem that you would face is that you address a different type of private partners. Integrated, you have a construction company, if I simplify, and then an operator. And you are forcing a marriage between two parties which would like to sort of naturally bond, right? Yeah. In the service base, you are sort of talking to mainly operators, which are then going to sort of get organized to fix the sort of infrastructure elements. That's how I would distinguish this, right? Importantly, to me, is really the service component there. How do you define this element? And I think when we were structuring the Uzbek dialysis for the government of Uzbekistan, we spent a lot of time defining what would attract an operator versus what would attract a construction company, right? Because the construction element was actually, I mean, it's not that it was unimportant because it's the framework of the service delivery. But what is important is how to attract the operator.
Yeah, super. Dr. Emad Dukair, you've done several projects across the globe in integrated PPPs, and on several of them you had to experience the efficiency that you brought in as part of your value proposition. Perhaps you can elaborate on those.
Thank you very much for having me here. What I always say, the first section of the construction element and the equipment, governments have always been using the private sector. Very, very rare did they go to a government company to build or a government company to equip as equipment. So those were always going to the private sector. The only thing that is really added is the financing. They're saying, listen, we'll give you the project and the equipping, but bring your money in. And sometimes, really, governments, even the financing in some of our countries around here and beyond, part of the financing is loaded on the private sector by not paying them on time. When they pay them 1 year and 2 years and 3 years late, this is indirectly they're using their money to finance the project. Out of our experience, the operation, which is the integrated part in this, is essential for it to be there as an operator from the very beginning, because, and I'll give a hotel as an example. If someone comes and says, I want to build a 5-star hotel, and then decides to call a Sheraton or a Four Seasons or the others, each one of those have got their own way of designing a room. So there is a lot of cost, which will be operator cost, which eventually the client is going to pay to amend and alter. In our previous experience with governments, the savings that we had in the UK, and it's all on the net and you can read it, almost 25% of the cost of tariff of the government. We're operating 25% cheaper than the government. In the Caribbean, 42% cheaper. In Poland, 28% cheaper. And I'm sure it'll be even a lot cheaper in our parts of the world. And this is not criticizing the government operator, because the government regulations really put the operator, the manager in a box. In the private sector, you have a lot more leeway to make sure that you're able to make efficiencies, savings. So it's the same government manager. If you tell him this is the money, do the same job without restrictions, I'm sure he will either save you 10-20% or give you 10-20% more product.
Thank you so much. I think, Vikram, you've been nodding your head. I'm sure you have some more to add to that.
Yeah, thanks, Nasser, for having me. I think for any integrated PPP, the way I look at it is there are 3 elements. The first element is clinical outcomes accountability. In general, in the government sector or the public sector, the accountability is not super clearly defined, and there is no major cost if the service provision is not up to the highest clinical standards. That, I believe, is a very important point in integrated PPPs. Second is the efficiency. I think what Dr. Emad said, the private sector operates with much more degrees of freedom than a public sector department or a organization. And the speed at which it operates is definitely slightly more beneficial for all the stakeholders if the private sector operates it. The third, I think, is more on the service level. In integrated healthcare PPPs, compared to a public sector operator, a private sector operator has to deliver on the SLAs, service level agreements, which in a well-designed PPP delivers a lot of benefits to the end customers, the patients. Now, the first clinical outcomes and this service level, I think these are very critical, while efficiency in terms of the financial efficiency is always a improvement. The clinical outcomes accountability does not get the attention it deserves in the integrated PPPs, I believe.
No, that's a very valid, very good point. And one of the projects we did was to monitor a dialysis project. I won't say where. We had the contract to monitor on behalf of the government the performance of the dialysis provider. And it gave us so many insights into, first of all, how to set the KPIs and then how to actually measure them. And really to see how difficult it is sometimes, how challenging it is to meet them, especially when in dialysis you don't have control over how people eat once they leave the center, and the dietary aspects and all of that. Fantastic point. Ustaz Ahmed, I know that your ministry has done several now and has launched several projects which have an integrated element. So from your perspective as government, what is the appeal to that? I think your button is not pressed. Yes.
Yeah, thank you. Thank you. I think it's one of the most important part when you come into a government, and as I was in the government for 31 years, been working in healthcare, to really come up and introduce a project with a PPP is not a matter which is an easy with anybody. And when it comes in the healthcare, that is the most sensitive. And when the healthcare services in our country is free. So that's by itself, it's built on a structure where we have an employees and they deliver, as mentioned by the panelists, the efficiency and the outcome and what is the value for money which comes in out to treat the customers as a patient, it's not there. So really the most, or the best thing that whoever wanted to implement the healthcare which is there, you need to really go to the upper level first and really to have to spend a lot of time of really defining and let them own that project before you start doing anything. And what I have seen is there, maybe I have not done that in the beginning, which is quite a lot, but we done it after that. That's why it took so long to really to come up with a certain project. And one of the projects that we are doing it with you, Mr. Nasser, your company, is a drug rehabilitation center. As you have mentioned, there is they were trying to find a model which is available somewhere which is there. It was an idea which came in, but so it was something new where it comes in that we bring up the private sector to come in and to get the government to allow to get the private sector to run it. That was really difficult, but I think it has succeeded. Took long, but in the next 1 to 2 weeks they will be appointing the first operator, and that will be the first real fully PPP project in Oman, which is coming, and there is many right now in the queue for those sort of projects. But I think the main part, you cannot go and do a project where usually people, what they want in the government, okay, we'll give them to do this, but we will be the people who will be managing, that mix. And remember when I was leading this, I said, no, we cannot do this or this, because we have done the pros and the cons of this type of project. And thanks God that has gone. We hope things goes in and it will be a success and it could be a good model, which is there.
تمام على خير. Dr. Mohamed, last but not least, briefly, what's your view on the appeal of providing the service with the clinical, so fully integrated?
I have to say that there is also a shift. The shift today that is more evident post the pandemic, because what we used to see with PPPs is that it allows government to empower, or it empowers government to leverage the private sector while keeping a hand on the monitoring side. But with integrated services today, we can see that we are ensuring, in fact, not only accessibility, inclusivity, but also the introduction of innovation. We are ensuring, as it was mentioned by my fellow panelists, improved efficiency, cost savings, better quality. And at the end of the day, I do believe that with integrated services, it is pushing somehow the public sector into improving the regulations. Because, and I will give a concrete example, when the pandemic did hit us in Zambia, so we wanted to increase as fast as we can screening, prevention, treating of patients with COVID-19, right? The first approach was a PPP, but then we found out that this was not possible because of regulations that may delay the implementation of such projects. So we went into what we are calling here integrated services PPP, but in fact the terminology was a little bit worked on, a makeover, may I say, which allowed us to move fast with the project and to be able to reach millions of people in rural areas. Thank you.
Yeah. So just to elaborate on that model, so when we see this in different parts of the world where because of the underinvestment in health services, the private sector on the part of the government, so whether it's infrastructure or the quality of services, the private sector tends to just step in and provide these services. And then when now there's the big imperative with the SDGs, SDG 3 and so on to provide universal health coverage. So some governments are actually turning to private sector providers who have already invested in the system to say, well, instead of ignoring you, let's bring you into the system, because the ultimate aim is universal health coverage rather than for the government itself to provide. And therefore, rather than necessarily do full-blown PPPs, they're entering into contracts to purchase that. And I think this is the model you were explaining. And Dr. Emad, I think there's a similar model in Saudi right now. On that.
إحالة, where the government outsource and they come and say we need those services provided, so different private providers kind of come and bid for it to take it as soon as possible. And it's all digitalized and electronics now.
Mm-hmm. And the UK ran a similar model, I think about
Patient
15
choice.
years ago, called Any Willing Provider, where again, after they did the first wave of integrated PPPs, which focused on orthopedics and ophthalmology, they also opened the door to others to take essentially the payment that is publicly paid, the public tariff, but provide so they can be Bupa or any other existing provider to do that. And I think that's a model we can start to explore more as we help governments achieve their UHC targets. Karine, I'd like to hear any comments you have on that.
Yes, thank you very much. This is a subject which is very sort of important to me because I think the way I see PPP is a sort of intermediary step towards a stage which you see in a number of developed countries where no matter where you go as a patient, the private sector or the public sector, you receive a publicly funded service.
Mm-hmm.
And of course, to reach that stage, it requires a number of regulations, requires a number of elements. And while developing all of that regulatory framework, while developing the health insurance fund, while developing all of what enables this stage, PPP is an intermediary step. Why? Because in one contract, you can put all the elements which allows to attract an operator. Now, contracting to me has two different features. Contracting is there to attract an operator with private assets. So with contracting, you do not necessarily improve the public services and the public assets. You just ask for a service. When I say just, it's not a way to minimize, but you are asking for a service to deliver to patients, privately delivered, publicly funded service. In PPP, it's in a sense privately delivered, but building the public capacity, right? That's the major difference in my view. So PPP would be an intermediary step. Next step would be, as we are trying to do also to help in Egypt, which is scaling the health insurance with the World Bank support, contracting private sector in private assets. And then next stage would be to have this equality of wherever you go, you get the service.
Mm-hmm. Fantastic. I wonder, Vikram, if there are examples like that in countries that you operate in where you can give us that.
Yes. So we currently, as NephroPlus, we operate 330 clinics across 200 cities in 4 countries. And one interesting example related to this is in Philippines, where we operate 26 clinics. These are all in private standalone facilities, dialysis facilities, where the PhilHealth, which is the Philippines insurance company, public funded, privately managed PhilHealth, reimburses a fixed price per dialysis treatment. So what you do is you build out this private capacity in private retail space, and then you get the empanelment with the PhilHealth insurance company. At the end of the month, you bill PhilHealth, and PhilHealth reimburses in 30 to 60 days. So in Uzbekistan, this is the exact opposite, where Uzbekistan government gave us just pieces of land in public hospitals campuses, and we built the whole buildings from scratch. And it's inside their facilities where we set up the private capacity in a BOT, build, operate and transfer model. So PPPs, we have seen many different variations. PhilHealth is an interesting example, Nasser.
Super. Ustaz Ahmed, I know that you have a purchase method as well in Oman, for certainly for dialysis services, but maybe for others as well.
Yeah, thank you. As I think whenever we should start doing a PPP, we always think to our setup, as we don't have a health social insurance in a country, so it's usually a government paid payment. The most part, I think people, they wanted to start from with the big projects. And I think that what really has failed, because what we have several examples in the region where they really started with the hospitals, and then they go and they start. So whenever you want to come in, that is really what happened, that the negativity about having a PPP. And also the one which would look there, that the private sector is not really a partner, but it's rather is coming, and they think that always whoever comes in is not for profit. So I think the best thing to really start is really to start with projects which can be quantified, and the delivery of the service is clear. When we did the dialysis, we know, okay, we gave the offtake of this many patient, which is there, and so they already has calculated, which is that it is a profitable, and we know from my being in the experience in the healthcare, and my background is a private. Really, what I have seen, the human resource is the big portion. So when you look at it between a government and between a private, there is almost 40% huge saving which is there when you look at which is it comes in. So I think starting with the project which are there like this, the dialysis is a very quantified. You can know it. You have a several KPI of the health status of a patient, if it is achievable by the operator, which they will do their maximum to really retain that. And with that one, they get paid. The most part, that payment, which is right now, is the most difficult, because if we go through the regular governmental payment, it could go 6 months and it goes a year to go on. But because of this is one of the mandates. It says that it has to be paid with a guarantee, as doctor has said, between 30 to 60 days, which is unacceptable, so it can go on. And I think these are the projects that you can go on. We have also done a project of a rehabilitation in a psychiatry hospital, but a daycare rehabilitation of the patient with the several ward plus the community, because it's a psychiatry. And it's also a new model which we are also bringing out. And the diagnostic services, it's another project which hope also it can be there in the pipeline, which will take up step.
Great.
So there is other projects which are there, but that's all.
Please take the opportunity to talk to Karine. They have case studies of 15 diagnostic centers that were done as PPPs in a document now. So
I have the initial studies on it to start with. When I was myself there, we looked at one, but it was a more comprehensive. It's not a unit, it's a region. So we took all the primary, secondary, tertiaries, diagnostic things which are a lab which are there. Plus we said we will allow the private sector also to utilize it. So it will be an attractive for the private to come in. So it will not be a model where you go into a tertiary core hospital and it's huge there. No, it's rather could be there. And as I said, it could be also that they do a capex on building or utilizing what is other services there to convert it instead. Because what we have in our setup right now, every health center, it has a lab and it has a radiology. But when we look at it, I've done a study, it's not efficient. The utilization is maybe 5%. But because we have given the service, you cannot pull.
yeah, and
So
the scope that they can provide becomes limited as well.
And it's the whole thing, it's transportation, by the way. It's nothing is there.
Yeah. Karine,
Yes,
you'd like
thanks.
to...
I mean, that would be very interesting to discuss. We indeed, the slide was there a few minutes back, but we indeed looked over a year we studied basically 15 different projects in diagnostics. So laboratory and radiology together or separate. Yes, over a year we interviewed a number of stakeholders, World Bank and IFC, and we are today publishing the report. So we hope that it will help PPP units and governments try to sort of take lessons from other countries, right? 15 different countries, and apply to their own. Why we did that is because after COVID, I mean, everybody wants to sort of develop their diagnostics. I think I don't have to argue so much to say that this is an absolutely important function. It has to function in the public sector, not only in the private.
Thank you. I want to change the topic and talk about defining requirements. When it comes to defining requirements in integrated PPPs as opposed to infrastructure PPPs. And I want to start with Dr. Emad, because I know we've on some projects that we've done with you, or there's been some interesting dynamics about how the government defined its requirements. Dr.
Thank you. One thing I'd like to bring to the attention, in the PPP, the most important P is the last P, which many times is not really implemented. The last P is a partnership. A lot of the time, the client still does not realize this is a partnership. There is still the feeling, I'm the client and you're the contractor. And this sometimes gets the project into a lot of hurdles and difficulties. And it's a state of mind, and I think it'll take a long time, but with a lot of education, that really it's a partnership where both must be winners, and it's not a client versus a project provider. But our PPPs, all of them, sorry, I'll raise my voice because it seems everything went quiet here.
No, we're hearing you.
Yeah. In all our projects, the differences, none of them were the same like the other. So it's not a one-size-fits-all. The requirement in the UK was a need to reduce a very long waiting list of something around 29 months for joint replacement and to bring it down to 6 months. And the government came and said, I will commit a certain number of cases at a particular price. You give us the solution. Our solution was building very quickly, in 11 months, a hospital in the car park of one of the major hospitals, and refurbish a wing in another hospital and cover a region of about 8 million people. And we managed in 5 years to reduce it substantially. But the big shock there was our doctor was doing 1.6 times the government doctor. And our theater was doing 1.8 times the government theater. And the reason is because of the construction and the way we constructed and the circulation. But the bigger shock was sometime our doctor is the government doctor. When he comes on a Wednesday and Friday, he does 16 operations and goes back on the rest of the week and does 10. And it was just the process that really made this differ. In the Caribbean, it was completely different. A whole country, small, 35,000 inhabitants, where they needed 2 brand new facilities, they couldn't afford it. So the money, which is about $125 million, was to be paid over a period of 20 years with cost of money. And it's private and public. So we took over more like the healthcare of the country. Our biggest problem was there was no national healthcare insurance. So the worry was at some stage we may not be paid. And so we worked with the government. 4 years later, a national healthcare insurance was built. But the sending abroad reduced from $50 million year one, just before we started, to $12 million. And when they calculated, in 4.5 years, the government paid for their whole capex in 4 years and 6 months, 4 years and 7 months of savings. In Poland is a complete different PPP than this one, where it was not a loan to the government, the capex, which is about $100 million. the government of the province could not afford such an amount. They had a very old, dilapidated hospital. They cannot build a new one. It will not meet the minimum EU requirements, so they had to close down. And so we won a bid where we raised the money. We built a new facility, and the deal was the minute we open, the government closed down. All patients will be transferred to the new facility with all the staff. And as you said earlier, 40% more than what we really needed. But we must keep them for a period of 3 years. And little by little, it's a 30-year concession. So no other license, private or public, in the whole region, 150,000 population, will be given as long as we can meet the public demand. The minute we fail, they can give another one. And they would guarantee us a minimum of whatever the government hospital generated the year before, which was in real terms 50 million riyals, because their services were limited. Our first year, the 50 million became 107. We built 107 because we increased the facility, the services. Second year, 137. This year, which is our third year, it's roughly 172. So a lot more services were provided for the region. But for the government not to have this as a loan, they came and they said the old hospital, and this is very much in our region, in the Middle East, the old hospital, which happens to be in the center of the city, which is dilapidated, we will not pay you a loan on your capex, but we'll give you the old site for the same duration of 30-year concession to develop into anything commercial that will generate money enough for you to cover for your capex. And so shopping mall, car park, housing. So one, they develop the center of the city at someone else's cost. They have a brand new hospital, more services that came in. And if there is a default from the private partner, then immediately they can give to someone else the services.
Yeah. Thank you for those examples, Dr. Emad. On the hospital in Poland, the way the government defined its requirement initially was that they wanted 410 beds. You remember that? And when we went, it's an EU country, so they run it under what's called the competitive dialogue. So in the competitive dialogue, they wanted feedback from the providers. And what we said to them was, I was with InterHealth Canada at the time, we said, you're not defining this in the right way. You shouldn't be telling us how many beds to provide you with. You should give us the case mix that you need to be done, and we will tell you what the number of beds is. Because we have different length of stay, utilization of operating theatres, and so on and so forth. How many beds were done in the end, Dr. Emad, as a starting point?
We built 360. The old hospital was 240. But first phase, we opened only 240, which now we're in our third year. We have some patients in the corridor because it's almost 100% capacity. And so we are now opening the third floor. But also the reason for this very high capacity really is the inability to do the most efficiencies in our operation still because of the culture there, as it is also in our parts of the world here. This is in Poland. It's very difficult to come and say, well, we have a joint replacement, day 2, maximum day 3, the patient can go home and we'll do physiotherapy at home. The family does not want to take that patient. So they end up staying with us for 3, 4, 5, 6 a week, 10 days at times. In the UK, we used to send them home on day 3. Mm-hmm. And so the turnover of the bed was so fast. Nowadays, the most recent operations in Riyadh, we just opened our first hospital. Patient goes home, comes in at 7 in the morning, have the joint replacement, and walks home at 7 in the evening. And we do physiotherapy at home.
Yeah, that's really impressive. So the measure of efficiency there from 410 beds down to 240, and the volumes that are being done there are like 2 or 3 times. Karine, we're often faced with kind of determining requirements for public sector projects that we've worked on with you, and you've worked on, of course, separately. Do you find a similar challenge when it comes to determining the capacity that the public sector should be doing?
Well, it always seems that the more number of beds you have, the more important you are. I come from France, and that used to be about 30 years ago the most important factor. Nowadays, we know that medicine is evolving, and actually you need less inpatient capacity, but you need more capacity to take over patients on an outpatient basis. And that's equally important. So, as you said, we start from the need. And then from the need, we define the inpatient and outpatient capacity that is requested. Also, interestingly, if I take the Uzbek dialysis case, you can take a number of patients outside of the premises of the hospital. With peritoneal dialysis, it's the case, home-based, and increase their life expectancy and also their quality of life. So I think it's very important to start from the need and then to try to develop the project to fulfill this need, not to plug in some sort of preconceived ideas. Yes, that's what I would respond to your question.
Yeah.
I have a lot of examples to share.
It's so true. And Vikram, please.
Can I just add to that? Can you hear?
Yeah, I can hear you better like this.
So one of the important things is many governments or the health ministries, they do not understand the subject area of that specific domain really well. That's where the domain experts like the transaction advisory services becomes very important, because the designing of the project is extremely critical, because you're setting up large infrastructure, large capacity. Designing requires a lot more effort at the beginning of the project, and that's where when you get a domain expert or a transaction advisor, they can talk to the various service providers and understand what are the different models they can bring to the place. For example, the way we discussed on the Oman project, many times what happens is some of the health ministries, they decide this is the way it is, you need to set up this capacity here, without truly understanding the domain very well. That's where I think the health ministries should work with transaction advisors who will work with service providers effectively during the design stage, so that the patients are getting the best care possible in the best design capacity model. Just wanted to share that.
Yeah. Ustaz Ahmed.
Thank you. I think the first thing is to really look at with both that this PPP, as he says, the last P is always neglected, but I always say it's a marriage, and it has to be counted this way. Usually, even the private sector on the other side, how to make up to take the best and most income out of it. But I think at the end of the day, it's a marriage, and we should really think, because this is a start of something, a new era in our region. We have also to be patient from the private to really help to go and to make this project as a success. And this is one of it, as she has mentioned right now. Peritoneal, when we come to a dialysis, we know peritoneal dialysis, a long term is a cost saving. Is not only from the what you call the procedure as overall. The life of that person is really slips. He's a human being who can go day to day. I mean, if some of you have seen the dialysis when we go, as I was managing at one time the dialysis centers, you know, you see how much they suffer, not only a patient, and the whole family and the whole thing, which is so really having the private, when they come, they should also look at it from that prospect, that to come in. We know that from the other side, the government, they are just new to it. But I think private should really come in and gradually help and maneuver and help of how, and tell them, hey, with all this is what we did also for your saving, and this is what we got satisfaction, and we have improved, we have cut on all this appointment and things which are there for these services as well.
Okay. Dr. Mohamed, I think one last word from you, and I'm afraid I have to bring this to a close after that.
If I may just add, I think I'm coming from Africa, so I will speak on behalf of that region. More than the building of infrastructure, I think what is needed is for governments to add into the requirements capacity building. When we are entering into a PPP or PSP, call it whatever you want, One thing that we stress on is what we can do to empower the skills and to transfer skills to the local talents. And that is very important if we talk about, for example, biomedical engineers. So it's not only about doctors and nurses, technicians, etc. Because one thing that we have noticed with BOTs, for example, when we build and we operate, then we transfer, is that why do these projects fail? Because there is somehow incapacity in maintaining the equipment, because maintenance contracts are very expensive in our region due to the fact that we lack skills. So I think it's one of the major areas where we should focus on, we should add that. And one last thought about the PSP, why we prefer them. Although there is a transfer of risk, it's not anymore a risk-sharing model. It's the fact that, and I think it was also mentioned indirectly, the fact that we operate a bit more efficiently because there is no room to lose from a private sector perspective. And therefore, those publicly funded services are not anymore seen as only provided by the private sector, but they are co-provided by private and public. Thank you.
Thank you so much. It's too bad we have to bring this to a close. I feel we're just actually warming up. It's been a really thrilling discussion. I thank you so much, esteemed panelists, and of course we can continue the discussion. I think the key message you can take out of this is that there's a lot of benefits and efficiencies that the integrated model can bring on a case-by-case basis. So please, when you as PPP units are looking at this, take that into account. Thank you.